Hello students, for this portion of your orientation we're going to be going over oxygenating the patient. Of course, the first thing you're going to want to do as you come into the room, introduce yourself to the patient. You're going to perform hand hygiene, don clean gloves, and then you're going to confirm the patient's name and date of birth with the patient, as long as the patient is alert and able to do so. Now, the next thing that we're going to do is we're going to go ahead and drop our side rail so that we can get in close and work with the patient. You only want to have the side rail down when you are at the patient's bedside. Otherwise, if you're going to step away, you do need to put the rail back up before you step away to get supplies or anything along those lines. Now, if your patient is in mild respiratory discomfort, in other words, they are satting okay, they're satting 88%, they're satting 91%, whatever the case may be, and maybe they feel a little bit uncomfortable. What we are going to do per ATI is we are going to start with our nasal cannula on this patient at 2 liters per minute. Okay, so once we have our tubing untangled and ready to go on the patient, we are going to take our tubing and hook it up to our oxygen first. We're going to then set our oxygen to the appropriate flow rate. We have this set to 2 liters per minute. That is where we start. And you want to make sure you've got oxygen coming out of the line before you put it on the patient's face. Now, the next thing we're going to do is we're going to insert it into the nares and up and behind the ears, and then we are going to adjust this so it will stay in place on our patient, which is difficult to do with the mannequin as he has no ears. Now, there you go. That is putting a nasal cannula on the patient. Again, this is used for a patient that is in mild respiratory discomfort. Now, if this is not sufficient to bring the patient's SpO2 up to where our target is, be that 94, 95%, we can titrate up 1 liter per minute at a time, okay? If your patient is struggling, this is not what we want to do. We would want to titrate this much quicker. Now, the flow rate on this is 1 to 6. So if you get to the point where you exceed 6 liters per minute with the nasal cannula, we're at 6 liters per minute, your patient is still not comfortable, they're still not saturating okay, we are then going to move to a simple mask for this patient. So the simple mask, as you can see, there are no check valves over here on the sides of the mask. There's no bag at the bottom. This is the flow rate on this per ATI is 5 to 8. Read your package insert. They're not all the same. This one happens to be 5 to 10. So we would go ahead and unhook our nasal cannula, take that off of our patient, and we're going to apply our simple mask. Again, before we put this on the patient, we want to make sure that the flow rate is appropriate for the device, that it is running, there's oxygen coming out of it before we put it over his face, and then we're going to go ahead and put it on his face, put the strap behind his head, adjust the nose piece to fit the patient's nose, and adjust your strap so that there's tension that will keep that in place on the patient. Now, at this point, if this is still not enough to keep your patient comfortable or to maintain oxygen saturation, we would be moving to what is called the non-rebreather mask. So, also, side note, if your patient is having respiratory difficulty from the get-go, you should be starting with the non-rebreather mask. That is, anytime the patient is in respiratory distress. So, if your patient is having difficulty breathing, this is where you want to start. When it's true difficulty breathing, your patient is huffing and puffing, they're hyperventilating, they're kind of cyanotic, they're turning blue. And as you can see, this is not enough air to inflate this bag. This must be set above 10 liters per minute. So the flow rate on this is 10 to 15. And we want to start with this turned up all the way to 15. You're going to hold your finger over the valve until this bag has inflated. If this bag is not inflated, the patient will not have enough air coming through this mask, and this is actually worse for the patient to be on their face than it would be to have nothing on there. So make sure your bag is inflated, make sure your valve is working appropriately, and then just as we did with the simple mask, you're going to place it over the patient's face. Make sure it's adjusted properly, it's comfortable, it's sitting on there, and now your patient has our highest flow rate that we can deliver with a regular oxygen delivery method. So Beyond this, if this is not effective at keeping your patient oxygenated, the next step we would move up to would be some form of forced air, which would be a CPAP or a BiPAP machine. Or if the patient is really doing bad, we would go ahead and intubate the patient and move on to placing a ventilator on the patient, which we'll be going over a little bit further in our next video. Now, as far as this goes, okay, in the event that the patient is not breathing on his own, you walk in the room and the patient is either has an ineffective respiratory rate, he's breathing 34 times a minute, very shallow and rapid, called hyperventilation, and it's not effective, as his SpO2 continues to drop because he's not taking an effective breath, or his respiratory rate drops below about 8 breaths per minute. So in other words, if he's going into respiratory distress from, say, a narcotic overdose, what we would then do is we would bag this patient. So we are going to go ahead and leave our oxygen at 15 liters per minute, and we are going to hook up our bag valve mask to our patient, to our oxygen. Now, if you're going to bag the patient, the first thing that you want to do is you want to move your bed out from the wall so that you can get behind the bed above the patient's head. The next thing that we're going to want to do is we want the patient laying flat so that we can bag him effectively. Now, on these beds, there's an emergency drop on the rail. Over here, you can see this. You depress the red portion of the lever, pull out the black portion of the lever, and this will drop the bed so that you can ventilate your patient or perform CPR. Now, for the bag valve mask, we are going to pull the bag apart so that it's expanded up. We want to make sure that all of our valves are in place, and we want to hook our bag up to oxygen. Just like our non-rebreather mask, this has an oxygen reservoir on it that you want to make sure is inflated before you start bagging your patient. So at this point, we're going to go ahead and make sure that our bag inflates up. There's no rips, tears, anything wrong with that. This balloon right here is our oxygen reservoir for the patient. And then you want to make sure you have the appropriate size mask to ventilate your patient. Now, the next thing you're going to want to do in this case is if you are right-handed, put the mask in your right hand. If you are left-handed, put the mask in your left hand. Whichever is your dominant hand is the one you're going to use to hold a seal on the patient. Now, what we do is we start up at the bridge of the nose. You are going to C-clamp this onto the patient's face. Now, to make this as effective as possible, we want to make sure his airway is open, so we're going to pull the pillow out from under the patient so he's laying flat. We're going to make sure that we tilt his head back. We're going to hold our fingers around the mask, and we're going to hold our other fingers on the bottom of his chin to make sure we have a good seal. Those of you that have smaller hands, if this is difficult for you to do, you can press down harder and roll the mask to the opposite side. That will actually help to seal on the other side where you can't reach if your fingers are too short. Otherwise, if you have additional rescuers available, if there's somebody else to help you, while they bag the patient and they squeeze the bag, you can hold a seal with both hands while they bag for you. Now, otherwise, if you're by yourself, when you are bagging this, the way that we time this is we squeeze the bag as we breathe in, and we let go of the bag as we breathe out. You are going to squeeze the bag and let go of the bag as you breathe. That should give you a respiratory rate of roughly 10 a minute, over about 6 seconds. So what we want to do is when we are squeezing the bag, we squeeze nice and evenly until your fingers touch. If it is a pediatric patient and all you have available is the larger bag, hopefully you have an appropriate size mask for the patient. And then what we would be doing is we would be squeezing roughly a quarter the volume of the bag. You only need a quarter for a ped and a half of the bag for an adult. Make sure that you're not overventilating the patient. If you overventilate the patient, if we squeeze down on the whole bag, what's going to happen is you're going to inflate the patient's stomach. When you inflate the patient's stomach, that is going to push the stomach contents back up. You're going to get basically regurgitation into the mask, and on the next breath it is going to go back into the patient's lungs, and that will cause aspiration pneumonia. It's really not good for the patient. Make sure you're not overventilating your patient. That is also why we do not pump this too quickly. Now, That all being said, if you do need to do compressions on your patient, when you are going to trade off for compressions, if I am standing here and my other rescuer, assistant please, is standing on this side of the patient, when I go to change sides so that I can perform compressions, he's fatigued, I'm going to take over compressions. I'm going to step to this side and he's going to step around this way. That way we are only moving back and forth around. Now if we need to go back, I'm fatigued, I'm tired of doing my compressions, we're going to trade back. At this point, I'm going to step back this way and he's going to rotate back the same side he was on originally. This means that you are not walking all the way around the patient and delaying your time. Now, to perform an effective compression on this patient, we do need a backboard under the patient because this mattress is too soft for an effective compression. Your backboard, if you do not have one on your crash cart or your crash cart is not immediately in the room when you begin to perform rescue breathing on your patient, your backboard is available here. As you can see here, this is the lever I was talking about to drop the bed. You would go ahead and push in this red button, pull the black lever out from the bed and push the bed flat. This gives you a flat surface to work on for the patient. The next thing we're going to do is we're going to take the brakes off, move the bed away from the wall so you can get in above the patient's head, put your brakes back on, and we want to put this patient on a backboard for the sake of having a hard surface to do compressions on. So at this point, I'm going to have my CNA come in and assist. I'm going to take the pillow out from under the patient. My CNA is going to turn the patient to the side. My backboard comes off the top of my bed. I'm going to place it under my patient. Go ahead and roll him back on there. All right, and we now have a hard surface to perform compressions on. Now, the next thing you want to do is you want to make sure that your bed is at hip height so you are not straining your back as you do your compressions. We're going to drop our rail down off of this side of the bed so that we can get at the patient to do our compressions. Now, to do an appropriate compression on this patient, you do need to visualize landmarks. So we would pull the patient's gown down. We're going to locate the sternum down the center of the chest, which should be in line with the patient's trachea and the xiphoid process. And we're going to locate the nipple line on the patient. This is going to form our little target for where we're going to place our hands. So you're going to take one hand, place that over the center of the patient's chest. You're going to take your other hand, place that on top of this one. You want to make sure that your elbows are locked, your shoulders are locked, and you are going to hinge at your hips to do a compression on the patient. We are not going to compress with our arms. We're going to compress with our upper body weight. Now, when you do an effective compression, it will be half the depth of the chest. We want to completely compress the heart to push the blood out of the heart. We want to allow full recoil so that the heart has a chance to refill. And we want to compress at a rate of 100 to 120 beats per minute. Now, that would be your appropriate compressions for the patient. At this point, if you have two rescuer CPR, one person can be bagging the patient while somebody else is doing compressions on the patient. So again, with my assistant here, he's going to be doing compressions, and when he becomes fatigued, we're going to switch off. So I'm going to hand the ambu bag to him. I'm going to step around to this side of the bed here, and I'm going to pick up compressions where he left off. When I become fatigued and we're going to switch back, we rotate back the opposite way. This way you are not walking around the bottom of the bed, and your time off of the patient performing compressions is minimized. Now, again, if we are doing compressions on the patient with multiple person CPR in the hospital, we can also hook this up to a capnographer and we can look at the waveform for ETCO2 on the patient. If the ETCO2 is between 10 and 15, your compressions are effective to support brain function on the patient. If they drop below 10 millimeters of mercury, that means that the patient is not being oxygenated enough by your compressions. Usually that's because of rescuer fatigue. So at that point, you would need to switch out with somebody else. Okay, and this concludes our CPR portion and oxygenation of the patient. The next thing I want to cover is if you have a patient that needs suction. So during a code, it is frequent that the patient will vomit, and we want to avoid aspiration. So if you see anything come up into the mask, If you hear the patient retching, maybe the person who's ventilating the patient has overventilated the patient, caused abdominal distension. At this point, we would go ahead and we'd want to suction out the oral pharynx of the patient to make sure that that's all clear. You're going to hook up your suction line to the vacuum canister. We want to make sure there's a vacuum canister present. If you just run it directly to the suction regulator, you are going to clog the regulator. So we want to make sure there's a vacuum canister there to catch whatever comes out of the patient. We're going to turn it to regular suction. You want it somewhere around 100 to 120 millimeters of mercury of suction. And we're going to suction the back of the patient's oral pharynx to get all of that vomitus out of the back of the throat so that the patient doesn't aspirate it in between breaths. And then this can also be used to suction your patient if, for example, they have excessive secretions on a patient who's trached or something else along those lines. We can still suction out their mouth with the Yonker catheter. But again, you need to make sure it is working appropriately and that you have the suction set appropriately. We don't want it too high. It can damage the tissue. We don't want it too low. It won't be effective. And then again, make sure you have your suction canister ready to go. Okay? All right, students, that completes our portion of the orientation.